This week on the BackTable Podcast.
We have to figure out some way to at least scratch the surface, because that also points me in the direction of we need to involve a mental health specialist in order to be holistic in how we're taking care of these patients. And often they already have one because they're dealing with other things. So sometimes my role is even explaining to them that in their mental health counseling sessions, they need to talk about the fact that they're having trouble breathing and bring some of those things together and think about ways in which they can address these sort of two issues, or at least understand there's a relationship between them.
This is Steve Schoeff joining from Tacoma, Washington. And I'm here with Dr. Steven Sims from Rush University Medical Center in Chicago. He earned his medical degree at Yale University and completed residency at the same place at Yale, followed by a fellowship at the one and only Vanderbilt Voice Center in Nashville. He shared that he commits to active listening and partnering with patients to help them achieve their goals. He sums up his care philosophy with the words of a hymn: "If I can help somebody, then my living shall not be in vain." I love that. When he is not with patients, Sims spends his time writing a musical with collaborators, also very cool. And he's a baritone singer and plays trombone, bassoon, and piano. So welcome, Dr. Sims. It's a real pleasure to have you on.
Thank you.
Our topic today is going to be inducible laryngeal obstruction, which I'm really excited about, because I find as a laryngologist, it's a very challenging condition and one for which I feel like, particularly if kind of first-line treatments work, it becomes a lot more challenging. And so I'm really excited to hear your insights and perspectives and experience with the disorder.
Absolutely.
Awesome. So without further ado, what I would love to hear from you is, I think one of the biggest things we get into, honestly, when I talk with my partners who are general ENTs and things like that, is the nomenclature keeps changing. And it's hard. It's really hard it's hard in laryngology to keep up with it, frankly. And so for our general ENTs, they're like, it's not PVFM, it's not VCD, what is it now? So if you can kind of set the stage for us in terms of the nomenclature and how we define inducible laryngeal obstruction and kind of what that's replacing terminology-wise and things like that.
Yeah. So, I think a lot of this just has to do with some shared territory and the concept of the unified and or shared airway. And the coined term of vocal cord dysfunction, was actually from a pulmonary medicine doctor, critical care specialist. And I think that a lot of why we began wanting to come up with a better nomenclature is vocal cord dysfunction is so terribly nonspecific. It's so general and so vague as to almost not mean much. And I say that because, like, if you have a paralyzed vocal fold, that's vocal cord dysfunction. In many ways, spasmodic dysphonia is vocal cord dysfunction. And so it's such a general term that it doesn't really get to the heart of what we are trying to address when you use such global concepts. And, I think the analog would be if someone had said, well, if you're having trouble breathing, let's call that lung dysfunction, not asthma. I think people would say, well, lung dysfunction, that's like really, really general. That's really, really broad. So maybe we can narrow this down to like reactive airway disease or the process that we actually think is going on. And so that was, I think, the evolution to paradoxical vocal fold dysfunction or paradoxical vocal fold movement or paradoxical vocal fold movement disorder. But as I'm going through that, I see how that became a tongue twister, and we sort of got a little tied up in using that terminology as well. So then inducible laryngeal obstruction is the most recent term, and one that, this concept is evolving. There are ways in which I think this is a more precise way to try to talk about what we're talking about. The idea that this is inducible, not static, not permanent. It does involve the larynx and it does involve a level of obstruction, but it is not something like a fixed obstruction that would, we would obviously manage differently. So I think we're moving towards a better way to describe this.
Okay, so we just got to clarify a little bit about the language around inducible laryngeal obstruction And it's always great to frame this in terms of the patient presentation, the patient concerns. And so talk to me a little bit about what you see with the patient coming in for this evaluation who's either sent to you with this diagnosis concern from pulmonology or maybe coming without any clear diagnosis. And in some ways, sometimes I think there's maybe two groups of people like that are presenting with these symptoms. But tell me a little bit of kind of what you think about with patients coming in with this disorder.
I think I have buckets that I think I put these patients in some ways because how I approach them is slightly different. And mentally, it helps me organize them and think about what my approach is going to be. Also, I think that moving towards patient-centered care is improved if we're really trying to think about, are there different phenotypes? And, fortunately, these are not my original ideas. Deb Fyland from Australia came up with these sort of 4 phenotypes. And even in her publication, she admitted there are more, sort of the classic, the lung-associated, the post-event, and then the exercise-induced. And I think like that as a general framework is a part of how I begin to think about these things. In terms of like how they present, it's usually the patients who say, well, like even that, there are a couple of categories, right? Some come in already having asthma, or at least that diagnosis. And often it's a situation where they have asthma and they've seen the pulmonologist and they do spirometry, they do a methacholine challenge, and that doesn't really align with what we think asthma is. That is one of the most common triggers to get them into our office to take a look at how the vocal folds are moving when they're breathing in. I think one of the challenges for me about that is often they're not symptomatic in the office and I don't see it. And I think my personal struggle is, if I don't see it, do I induce symptoms just so I can see it? Because I don't know that that's going to change how I treat it. And quite frankly, it doesn't feel good to have stridor and feel short of breath. So I'm always like, it may help me some to induce the symptoms so that we can have it captured. We always video our exams, and so that we could have concrete sort of evidence that this is the phenomenon that's going on that explains some of the symptoms that the patients have. But I think I've moved away from doing that just because it is such an adverse event to be struggling to get air in. And I think doing that just so we can see it might not be the most productive way to proceed with these patients. But again, I think that the ones who are exercise-induced almost purely, I think are some of the ones who do the best with just some breathing retraining and working with our speech pathologists. So I do listen very attentively when I'm taking their history, because if I can pick up those sort of clues, and often they come in and say, this is only a problem when I run, or only a problem when I bike, or only a problem when I play softball, volleyball, swim, whatever it is. If we can zero in on a trigger and a response, those are the people I'm more comfortable saying, well, let's start by working with the speech pathologist, some breathing retraining. Another bucket are the people who probably do have some degree of reactive airway disease, maybe even a little irritation from reflux laryngitis. So, there's some clinical things underlying this, but maybe there's a bit of an exaggerated response. So they're a little different just in terms of how we approach them. And sometimes it manifests as cough, sometimes it manifests as throat clearing, other times it manifests as shortness of breath. So I think teasing all of those things out is really important in terms of how we proceed. I think the other group that we've talked about, I've published on this, but I don't always think gets talked about as much, are the people who are coming in post-trauma, and specifically after an unwanted sexual experience of some type. We have really taken to administering some questionnaires, some trauma questionnaires, and looking at some PTSD symptomatology, and found that just a lot of our patients have this facet of the disorder that often hasn't been appreciated before. And I think a lot of times I'm even surprised by the patients who say, no one ever asked me about that before. And, you sort of see the connection being made in the office, and it doesn't fix it right away, of course, but it does open up a new pathway and a new frame for how we look at this and what are the things that we can do to make it better.
Yeah, it's a really interesting point. I know, my fellowship mentor, Seth Daly, really emphasized that in consideration of contributions to different laryngeal disorders. And I even saw a voice disorder kind of resolve with somebody who recognized a choking incident as a younger person that had really contributed to neck trauma.
Yeah.
So it's a really interesting point. So thinking about this, and particularly for the general otolaryngologist who's getting asked to say, okay, we often get this referral and it says, can you look at the vocal cords and see if there's vocal cord dysfunction? That's the classic referral I get. And I'm trying to kind of work through that. But at the same time, you think, okay, can you look at the vocal cords and see if there's vocal cords dysfunction? And I tell them, I'm probably not going to see anything. And so thinking about it kind of for the general ENT and how they approach this, I think, for me, at least logically, like you mentioned, this idea of the buckets, and I almost think of our sort of exercise population as one, and demographically tends to be a little different as well. It's more likely to be teenagers, I think, has been my experience and things of that nature. And then thinking of kind of some of these other multifactorial, maybe trauma related, maybe asthma related, maybe truly hypersensitive larynx response to chemicals and scents and things of that nature. And unfortunately, I see that a lot in nursing college. I've seen a number of patients who are in healthcare in some way and had a exposure to a cleaning agent or something like that and end up down this spiral. I've cared for a number of patients like that. And so for me, conceptually kind of, and you laid those buckets out. And so let's maybe tackle kind of one side of that first and then maybe the other. And so, because I do think, like you mentioned, the management or the response to management can be different as well.
Yeah, absolutely.
So let's think about maybe set aside the exercise-induced first and think about this sort of the other buckets, so to speak, the other groups, and coming in with maybe a less certain picture, less clear picture. And how do you stepwise evaluate that patient? You mentioned not trying to induce a spasm, but what would you look at in clinic? What data do you feel like is going to really inform you? And you mentioned, of course, the history, and what are kind of those key history points you'd hit on?
Yeah, absolutely. The history. I'm looking for, even some of the things that you mentioned. Do they have a fairly well identified trigger? Now, even if it's some inhaled noxious stimuli, that could be all kinds of different things. But I'm looking for that. Like, do they say if they're walking through a department store and they're fearful of someone spraying them with a perfume or a cologne because they know that something that they breathe in like that will trigger them? Are they afraid of working with certain cleaning solutions, like things that they already have a sense that they may have an exaggerated response to that? And, as you listen, the patients will usually tell you all of the things that kind of guide what their experience is. And so those are some of the key points that I'm listening for as they're telling their story and as we're asking our questions. Because then I start thinking more about that bucket of true chemosensitivity of the larynx that is often triggered by something that was inhaled, but we really are thinking about an exaggerated, somewhat hyperactive, hypersensitive response. Those are the patients, I think, all the patients, as I scope them, I am looking for even like subtle tendencies towards the vocal folds adducting when they're breathing in. And I often have them do maximum gestures. So I'll have them say E, and then I'll have them sniff, and I'll have them just keep repeating that really, really quickly to see, like, do I see sharp abduction on each sniff and sharp adduction with each phonation, or do I see becoming a little fuzzy as they keep doing it really rapidly? So that's one of the tests that I think can give me a little bit of a clue and not put the patient through something that is much more uncomfortable. But a lot of times, even that, like, I really don't see that much abnormality on the exam.
Absolutely.
So then I go back to the history and say, well, clearly there's something that's going on. So then I start thinking about, with the hypersensitive people, what are the neuromodulators that we can try and see if they get any benefit from that. So I use amitriptyline, I use gabapentin, I use Liorsal from time to time, baclofen. And really, we go through the discussion about, well, first, what are some of the marketing ways in which these medications are marketed? Because I certainly don't want them going to the pharmacist and saying, what? He's giving me a medication for depression? I'm not depressed. So, we walk through.
Yeah, I've heard that one.
Yeah, but I feel like no surprises, no ambush. Yeah. So I'm going to tell you, this medication is marketed to treat depression. However, it can be used for pain. It can be used for cough. It has properties that help calm down a hypersensitive nerve. And I think that that's what you have. So that specific property is what we're going to treat. We're going to start you on a low dose. The side effects are that you might get really tired, but, we'll try to gradually titrate up the dose, particularly if it's beginning to help you, and then, see where we go with that. And I think if you lay that out for patients, they don't feel betrayed. They don't feel like you were trying to sneak something in, and they can understand that we are taking advantage of the properties of the medication and doing our best to help them feel better. So, but I go through that, and then I say gabapentin is more marketed to treat seizures, but it can be used for pain. Baclofen, Liorsal is used to treat spasms, but it can be used in this particular setting. And just, be open and honest and have the dialogue. And of course, I have all this written down that can be an insert in their after visit summary. So helps remind them, yes, we did have this conversation. And, I did explain these things to you, because one of the worst things is when they come back from the pharmacist and they're like, why didn't you tell me you were going to do this? So,
Well, and importantly, remembering that I think it's 50% of what we say is forgotten the moment somebody walks out the door. So
yeah, which is why I always write it down.
Really helpful. Yeah, absolutely. And we're rushing through these. Unfortunately, we have to rush through these evaluations, right? I mean, these could take an hour, and we usually aren't given anywhere close to that.
Yeah, nowhere near that. And so that is that approach. And then I think the ones that I perceive, and you were talking about this with your mentor, even as you approach the neck, you see how the patient recoils from that, and you get the sense that something bad happened. And, I just learned to start asking about that, just based on, that sort of tactile response. And so I think that has just helped me lean into asking some of those questions when that phenotype of patient comes in. And like I said, I've just gotten so much information about adverse childhood events, things that have happened to people in their lives that often they've just buried and willed themselves into moving forward, but there's some conflict that's still underlying that. So those are the patients that I will more likely administer one of the questionnaires. So there's the life events checklist and the PTSD checklist, both coming out of PTSD research and trauma-informed care. And I just found that those are like tools that help usher us into conversations that sometimes, for the reasons we were just talking about, like these patients can be very complex, and opening Pandora's box, you might get a lot. But I feel like we have to figure out some way to at least scratch the surface, because that also points me in the direction of we need to involve a mental health specialist in order to be holistic in how we're taking care of these patients. And often they already have one because they're dealing with other things. So sometimes my role is even explaining to them that in their mental health counseling sessions, they need to talk about the fact that they're having trouble breathing, and bring some of those things together and think about ways in which they can address these sort of two issues, or at least understand there's a relationship between them.
Absolutely. Yeah, these are really good points. And I think in particular, it's great to bring up that questionnaire as a potential resource. And I didn't mention, or we haven't talked about, but presumably you're doing a lot of these visits in an interdisciplinary setting, or are you usually doing them by yourself without a speech pathologist?
The speech pathologists are near, but they're not necessarily seeing the patients with me.
Okay. Yeah, and obviously every voice clinic is set up differently, and I do some of both, and a lot of surgeons do as well. So that's always kind of part of it as well, because I find having the speech pathologist often there is a really great kind of additional team member to help you in this evaluation, and they often have maybe a little bit more time as well to kind of really delve into things with the patient as well.
And for better or for worse, a lot of what they do is actually trauma-informed care. Like they're focused on breathing and mindfulness, and those types of techniques actually are going to help the patient either way. But that's one of the other things I think I've evolved into, is understanding that it works, but like knowing why it works is also helpful, just in terms of, because I think a lot of times one of our first responses is to say, well, I don't think they need a neuromodulator. I don't think they need Botox. I don't think they need a superior laryngeal nerve block. So let's start with speech pathology. And they do get better, but for me, at least, understanding why they get better, or teasing out that some of this is treating the trauma, helps me in terms of how we move forward, and help the patient understand what trauma-informed care looks like. Because I think that a lot of times they can have this notion that I don't want to see a psychiatrist. I don't want to see a mental health professional. I want to do this on my own, or whatever notion of that might make me weak. That means that something I thought I had put in my past isn't in my past. I think there's lots of issues that can surround that, but the way in which we can make it a little bit more palatable and accessible is important. But I just want to name that with the patient so that we can think about strategies moving forward.
Absolutely. Well, so kind of beyond that, then, in terms of thinking about, again, still mostly this kind of group of patients rather than the exercise-induced, we'll get to those.
Yeah.
But thinking about kind of what additional testing do you feel is mandatory? What additional testing might be directed by the patient complaints? And so kind of thinking about pulmonary function testing, maybe reflux testing, kind of what do you feel like typically you need, and what might you like depending on the patient or the scenario?
Now, some of this is just, based on the type of practice and my location and setting. Most of the patients come to me from the pulmonologist, so they've already had the complete workup. I probably would be a little more judicious in the people that I got spirometry on, but most of them come with that already. So, I of course assess it and use that information to think about what I might do for the patients. But I don't think it's a make or break for me. It's just that it's additional information, so I use it. I think with the cough patients, or the ones who, present with more of a throat clearing, almost a vocal tic behavior, or like that ilk of what the presentation is, I think more about making sure we're controlling reflux and other types of triggers. Those are the people that I might, suggest some vitamin B12, just to be complete about how we're approaching it and treating it. But I don't think I get all that much more sort of clinical information or testing for those patients.
Yeah, I think that makes a lot of sense. I feel the same way, although I sometimes get more that haven't had that level of pulmonary workup. So I might say, well, let's just make sure that asthma is not there. Because it's easy to, I think sometimes in our niche, it's easy to forget asthma is really, really common. Right.
Yeah.
And it, funny enough, my personal story is that when I was, a young teenager, I had inducible laryngeal obstruction because I was struggling to breathe. And fortunately, I kind of grew out of the asthma, and so I stopped
from the asthma.
But I'm like, I thought back, I'm like, oh gosh, that's why I was struggling so badly. And so it's kind of a funny thing to, kind of keep in mind, but of course people can have multiple things.
And of course, I'm always on the lookout for the subglottic stenosis masquerading as asthma, and thinking about
and masquerading as ILO too.
So we always look just to be sure that I'm not seeing some level of fixed obstruction, and I do think it's important to clear that. But I think once I sort of see normal structural underpinning, then I don't order all that many other tests. But I guess, again, it's because I don't see that many people who don't come from already having had a pulmonary workup. And if I did, I likely would send them to see the pulmonologist, just again, so we're complete and we have as much information as we can.
Well, great. And so we've touched on management strategies a little bit. So we're thinking about for the more irritable larynx type picture, that general picture, thinking neuromodulators. We touched a little bit on speech pathology and its role, but maybe to kind of pull it all together. So, so you're seeing a patient, they definitely have some irritable larynx type features. You think about neuromodulators, you think about involving speech pathology. How do you usually see that treatment strategy playing out, and where are some of the maybe pitfalls or places where you feel like, okay, now, this isn't working, we need to move to next steps, and how do you approach that?
Yeah, I think even that is very individual. Sometimes for the patients who, just have this intense urge or sensation in the glottis, I'll just do a local block, transtracheal block or something like that with like 2% lidocaine in the office, if they're up for it. And just see, like, if I suppress some of the sensation there, do you feel better? And then that can help guide me towards, okay, well then here are some of the things that we can start moving towards to see if this helps you. And then those might be the people I think more about, well, perhaps a superior laryngeal nerve block paradigm for you. I used to do more just unilateral, but I do believe in the phenomenon that there's some cross-innervation in the larynx. And if you're not too concerned about potential swallowing issues, doing both sides at the same time, I've done more of that as I've evolved in doing this. So yeah, but again, I think, you set it up and tell them at least like what the overall plan is. Cause I think one of the worst things too is that they've been struggling with this and they know that there's something wrong. And a lot of times they've had a lot of, well, I can't tell you what it is. I can only tell you what it isn't. And so you do want them to leave with something. And for me, like even that transtracheal block sometimes is like just a little hope. And I tell them like, this is not going to last. If it helps you, that's great. But I'm telling you on the front end, it's going to wear off. But it does help me figure out like what our next step might be.
Yeah. And what kind of role do you find for Botox? I don't know if I know a lot of folks I talk to, and myself included, will kind of bring in Botox at times. Sometimes I feel like it's my magic wand or my kind of final pathway. But do you use Botox at all or much in these patients?
So again, I think, it goes back to like the phenotype and what kind of symptoms am I seeing. So the people who have very occasional bouts, I'll still bring it up because I want them to be involved in the decision. So I will give them the full spectrum of things that I can do, but then sort of say, one of the things about Botox is it's not selective. Like if I put it in the muscles, it's gonna affect those muscles after, about 48 hours. And so you may go from sounding like this to sounding like this. Yep. And that will happen whether you're having symptoms or not, because it sort of shifts the whole paradigm. And so the times when your muscles want to be tight, it will keep them from being tight. But the times where they're normal, it may make them a little more loose. And as long as we can agree that that's worth it to them, to maybe have a little bit of a breathy voice and some of those side effects, to have a good shot at suppressing those instances, then I'm like, yeah, let's do it. But I think that really becomes the patient who is having more frequent symptoms.
Are you typically then doing the classic EMG guided true vocal fold injection then for those patients? Yes. And what kind of dosing do you usually start with?
I would say it depends, but probably no more than 2 to start. 2 units, I should say, in each thyroidnoid muscle.
Okay.
And sometimes a little less than that, depending.
Yeah, it's very rare I get down there, but I've incorporated occasionally trying the false vocal fold, hoping for a little bit less side effects. But effect is definitely variable. Have you found that it's in your hands? You've had pretty consistent success in those patients who have gotten all the way there in terms of the pathway?
So I think, yeah, the ones who are having a burden of symptoms that is so frequent and so severe that they are interested in Botox, I think it's effective for them. But, I think the selection of those patients is really highly predictive of success, which, we shouldn't use it indiscriminately, which was always the case. But I do find that they do better. It's true that sometimes if I'm really, really trying to get the false focal folds, I'll actually use a channeled scope and do it under visualization instead of the EMG machine. I, at least, can be much more precise if I am looking through the scope to get to the false focal folds.
Yeah, that's typically how, or I may do it thyrohyalate approach, under scope visualization. Yeah. And I've definitely seen, for some patients that, they're able to tolerate that a little better, but it's very rare. I can't think of anybody that I'm actively treating in this way. So yeah, it's fortunately pretty rare. One other thought process is, so say somebody is just having spasm after spasm, and I've encountered these patients actually after kind of all the Botox trials and things like that, it'd be where I've actually had one come ask me for a tracheostomy. Have you ever done that? Or any thoughts about kind of putting in tracheostomy for patients who just are having repeated episodes of this? Or do you feel like there's always an alternative?
So I guess fortunately, I've only encountered one patient like that. And the thing that kept me from proceeding with the tracheostomy is that when I looked in there, they were wide open. And so I appreciated that her sensation was that they were spasming shut, but I had no clinical evidence to support that. And so I told her, I can't really justify placing a trach in you because visually your vocal folds are open, your airway is patent. And of course that was difficult for her to hear. And
so she was actively feeling that she was closed, but you could see her open in that time frame. Okay.
And a lot of times, even that biofeedback helps people, but it didn't help this patient.
Yeah, absolutely. And we didn't talk about biofeedback yet, but I absolutely am a huge fan of that, and particularly in the interdisciplinary setting, even more so, I think. But yeah, I did talk a little bit about what you do for biofeedback and what you find with that.
Yeah, I mean, and you're right. Our speech pathologist often has a little more time and well, they're all of them. I was going to say she, but there's more than one. All of them are great and can scope patients themselves and can really say, I just want you to be able to see what's happening, because sometimes internally, this is what you feel is happening, but it may help you to see structurally, functionally, what we see actually going on. And, not every patient can respond to that and receive that, but I think the majority of them do really well with you having a screen where they can see in real time, this is what's happening as I'm scoping you. This is what I am seeing as you were feeling these things going on. And I think then being able to say, if you try to do this, whether it's pursed lip breathing or Beethoven breathing or whatever type of intervention that we come up with to try to help them feel the difference, if they can also see the way in which the structures change, I think that's invaluable in terms of how it equips the patients to know what's going on and be able to take some control. And I think, bring all of this full circle, I think a lot of these patients, that's a big part of what creates the anxiety and the angst, is that it feels like there's no control and they've lost control and there's nothing that they can do. And this is something that is imposed upon them. And they're looking for, how do I reestablish agency and be able to take some control over this? So I definitely think, biofeedback is really helpful for that particular group.
And that's a really cool point you make. I think that sums us up so well, this idea of agency and getting into the mind-body connection and the feeling that your throat is doing something that's out of your control, the stress that provides or induces. And so I think that's a really, really great point and almost the crux of the challenge that we face for, all our different interventions. Yeah, I think that's really thoughtful. So I think my thought here is to transition a little bit to the exercise-induced laryngeal obstruction. Any other thoughts on kind of this group of patients, management strategies, things that pearls that might really help our, particularly, a general ENT who's trying to help patients and maybe doesn't have a interdisciplinary voice clinic down the road to work through. Yeah.
I mean, I think like for me, one of the most accessible, I think, concepts for this is like straw phonation and just helping people figure out how they can purse their lips, produce a little back pressure on the vocal folds, and that will just help them open.
Describe to us a little more detail, kind of what you show them, how you direct them, if you can.
I mean, I don't want to oversimplify because it is complicated, right. but I think that is accessible. Like when the patients are beginning to feel short of breath, if you have them, and this is why Karen Wicklund taught me, it's not her technique, but the Beethoven breathing, where you dun 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 dun, and so you have them do 3 short breaths and then a longer one. So
all on the
pursed
exhale.
Lips. Sorry.
All on the exhale.
Yeah.
On the exhale. Cool.
And that's actually a pretty successful technique that I've used in the office with this particular group. To use my speech pathology terms, that group is very stimulable. And I think that just redirecting them a little bit is very helpful. And, if we think about, again, that phenotype, this tends to be the high achieving type A personality. If you give them something, they will be all over it and will typically run with it, be very compliant, and will do well with just a little bit of cueing.
And when you say that, that makes me think of our exercise group. Is that who you mean, the type A sort of high achieving?
Yes.
Yeah,
that's what I was talking about.
Exercise-Induced Laryngeal Obstruction. Yeah, perfect. I totally agree. They're just like, they're there and they're ready to go and they just want it fixed, and they're a kind of fun population to work with. So you talked a little bit earlier on that you find the exercise-induced group, you're in clinic, not necessarily trying to induce the laryngeal obstruction, but relying on that history, but then mentioning, you've seen them have a lot of success working with speech therapy, speech language pathologists, and any kind of pearls or tips on your experience there beyond what you just described in terms of kind of working on straw phonation and working on that breathing biofeedback.
I think that those, for me, have been some of the most consistently successful strategies for them. And again, like I'm not trying to minimize this group, but they tend to be one of the more straightforward ones. And I think that's why I've evolved now to not necessarily, because I used to put them on the treadmill or have them run up and down the stairs outside and then come back and, we'd scope them again and take a look. But I realized that my approach to them is still going to be about the same. And so why put them through that jarring experience when I think I'm going to just start with, let's do some breathing exercises. And very often they pick that up, adapt to it very quickly, start feeling better, and we're able to build on that. In the perfect world, those are the people that I would like to have see the speech pathologist that day. Just go down the hall and see them, but I don't always have that opportunity. But I think still, those are the ones that we can build pretty quickly on. These are where, that biofeedback piece of it. We do the scope. I show them these are your vocal folds. This is what should be happening. When you breathe in, they should open. When you speak, they should close. What I see here, if we see that, is a little bit of just a little quivering when you're breathing in. So I think, there may be a little bit of a tendency for them to move in the wrong direction. And here are some things that we can do to help train them and also reassure the patient that even though this feels terrible and it's very scary, the extreme likelihood is that you will be fine. And as you've experienced, if you were able to stop doing the exercise and then focus on the breathing, this should break. I think leaning into the way in which this is not going to become progressive in the vast majority of cases also just helps the patient, again, know this is what could happen, this is what I need to do, and then they can move forward a little differently.
That's great. And like you mentioned, these are also often patients who really desperately want to be in control of this because, they're often competing in athletics and things like that. have you run into patients where I unfortunately had to run into a couple where they've actually worked a lot with speech pathologists, a lot, multiple ENTs, and are coming to me because they haven't been able to find ways to break the cycle. And I generally don't think there's a huge role for neuromodulators or Botox or things like that in these patients. What are your thoughts on how to approach that kind of patient, where they have the classic exercise-induced laryngeal obstruction, but aren't necessarily seeing the gains that we would hope to see with the typical interventions?
Those are the ones that I might consider. Like, I do think there is a role for a nerve block, a transtracheal block, like a lidocaine block, just to see if we interrupt these pathways, if for whatever reason on the subconscious level, there is access to a pathway to where you're going to keep getting a very similar response. If I interrupt that, what happens? And since it's going to wear off, I'm like, we can try it. It may open a window for us to find some different cues, some different responses to stimulation, whatever. So I think that's probably the thing I think about most for that recalcitrant group is like, okay, well then how do we interrupt this temporarily and see what window that opens for us? How do we move forward? What did it feel like for you when I did that? Now, some patients have said, nah, it changed for a couple of hours and then it came right back. Then I'm a little stuck, but at least it helps me sort of have a sense of where we would move next.
Well, yeah, and if you see that response, maybe there is a role for Botox or some other kind of longer term attempt at sensory neural alteration.
Yes.
So yeah, that makes a lot of sense. Yeah. Well, great. I think those are the main points that I wanted to hit. I think it's been a really helpful conversation thinking about this disorder and how we can approach it for so many different patients. What other thoughts do you have?
I guess I'm still thinking, because I want to try to make this accessible to my comprehensive otolaryngology colleagues. They might not necessarily feel that comfortable doing a transtracheal block, and they're probably not going to give the Botox. So in that setting, definitely speech pathologists, which are going to be, I think, more accessible, can often have a lot of behavioral input and habitual input to help the patient feel better about it. Not always, as you point out. I think some of those patients are still going to be a challenge, but I think involving that skill set will be of great benefit to the comprehensive otolaryngologist. And again, even the pulmonologist will continue to be helpful with symptom management and things like that. And then at some point, if it is feasible or we're not too far away, getting access to someone with a little bit more subspecialty training probably makes sense.
Absolutely. I think that's a really great point to wrap up on. And I spend every episode mentioning how great our speech pathology colleagues are. So I never want to forget. I've been so lucky to work with so many tremendous speech pathologists over the years and continue to work with them daily. So it's such a great part of the team in managing, managing these conditions. Yeah. And particularly this one, I think they have just such a huge role. So,
absolutely.
Well, excellent. Thank you so much for joining us today. It's been a real pleasure to hear from you and get your perspective, and wish you all the best going forward.
Thank you so much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe Lagrezio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.